صوتي واضح؟
Yes.
واضح.
Okay. بسم الله. Okay. Hello everyone. My name is Faisal Ghamdi. I'm a cardiac surgery resident from King Faisal Cardiac Center. Today I will be talking about aortic dissection, mainly about definition and presentation and how to manage this disease, mainly medically and surgically. The surgical management or the surgical intervention for this disease is very similar to the management of aortic aneurysm. So I don't think I'll be adding anything new regarding the surgical management. Before I start, I just want to say one thing. If you don't mind, I want the first part, which is regarding introduction and presentation and incidence and epidemiology to be one part, and we leave the questions until the end of this part, and then once we reach the intervention, we can have a discussion which will make it even more useful, I think. So aortic dissection, these are the content of my presentation. I'll talk briefly about acute aortic syndrome and aortic dissection. Before we delve into aortic dissection, we need to know that aortic dissection is part of a syndrome that is called acute aortic syndrome. It is made of a number of life-threatening aortic conditions. These conditions are aortic dissection, which is the most common, and then we have aortic intramural hematoma, and then the penetrating aortic ulcer, and periaortic hematoma, and intimal tear without hematoma. The classification of these conditions are similar to aortic dissection regarding the chronologic, meaning whether the timing for definition of time definition of subacute or acute or chronic, or the anatomic classification. We have aortic intramural hematoma type A and type B, the same way we have in aortic dissection and the same definition. This is just a picture I took from up to date, just summarizing all these conditions. We have the first picture, which is aortic dissection. The second one is intramural hematoma. The difference between the first one and the second one is that the first one has an intimal tear with flow from the true lumen of the from the aorta into the false lumen. While in the intramural aortic intramural hematoma, there is no apparent tear. And the third thing, which is penetrating aortic ulcer, this one, there is a small tear which usually happen in atherosclerotic plaques, and it penetrates into the layers below the intima, but it does not cause a flap on the false lumen. And we have periaortic hematoma, and the last one is the iatrogenic dissection. Sorry, I meant for class 4, it looks similar. Class 4 should represent the atherosclerotic ulcer. Okay, so now we will delve into aortic dissection. We will start with definition. For aortic dissection is the separation of the aortic wall layers due to the intimal tear. And there is a famous registry, which is the International Registry of Aortic Dissection, where most of the epidemiologic information about dissection comes from. And the epidemiology of aortic dissection, the worldwide prevalence is 2.6 to 3.5 per 100,000 patients per year. The peak of admission for the aortic dissection usually happens during the winter seasons. And the aortic dissection usually tends to be to happen in males who are 60 to 80 year olds. For the classification of aortic dissection, I like to think of it are 4 types of classification. We have the chronologic classification, meaning since the time of presentation, and we have the hyperacute presentation. We have So we have the hyperacute presentation, which is since onset of symptoms. The onset of symptoms is less than 24 hours, and we have the acute classification, which is anything less than 14 days, and the subacute from 14 to 90 days, and the chronic is more than 90 days. The anatomic classification, it is based mainly on the intimal tear location and the extent of the dissection. And I will be talking more about this type of classification in the next slide. But before we talk about it, let's just talk quickly on the other types of classification. We can classify dissection clinically, either as complicated or non-complicated, depending on the things that happen because of the aortic dissection, either organ malperfusion, myocardial ischemia, stroke, or spinal cord ischemia. And also due to the etiology. Either it's degenerative, which mainly what happens in older patients, or genetic, which can be part of syndromes or non-syndromic, or traumatic due to trauma. So the anatomic classification, we have two types of anatomic classification. We have the Stanford or daily classification. It is mainly functional classification. It's practical and simple, and it is the most used, and it's used during for management. And there are two types. We have type A, which mainly involves the ascending aorta, and type B, which does not involve the ascending aorta. I read recently that if let's pretend that an aortic dissection only involves the arch of the aorta. So we would consider that as a type A aortic dissection. For the Baker classification, it is mainly based on the location of the primary intimal tear and the extent of the dissection. It is good for comparative research because it's more detailed, and we have in it 4 types. This graph shows all types of the Baker and Stanford classification. So the first 2 are considered type A because both involve the ascending aorta, even though the first one goes all the way to the descending thoracic and abdominal aorta. For the two on the right are considered type B because they spare the aortic arch and the ascending aorta and only involve the descending aorta and abdominal aorta. This is for the Stanford. For the DeBakey, it's concerned mainly about the origin of the primary tear and the extent of the dissection. In the first one, which is type 1, the primary tear happens in the ascending aorta. So this is considered type 1, regardless of the extension of the dissection. For type 2, sorry, it's not regardless, it's type 1 and it extends all over the aorta. Type 2, it's the same location of the primary tear, but it only involves the ascending aorta. Type 3, there are 2 types in type 3. We have type 3A and type 3B. Type 3, it's a dissection with a tear that happens after the left subclavian artery. For type 3A, the extent of the dissection goes up to the diaphragm. For type 3B, goes after the diaphragm. So regarding the etiology of the aortic dissection, we have the spontaneous aortic dissection happens either spontaneously or due to iatrogenic causes. For spontaneously, we have multiple theories. We have the biomechanical abnormalities. This involves biomechanical abnormalities involves also the hypertension, because this causes a biomechanical abnormality because of its high stress and high pressure. Also, the bicuspid aortic valve, due to abnormal flow, they have higher rate of dissection than normal population. Also, patients with abnormal aortic tissue, especially patients with Marfan or Ehlers-Danlos, patients who have the cystic medial necrosis. because also this affects the aortic tissue. Another theory is the intramural hematoma. It's thought that dissection happens because of bleeding into the vasa vasorum that supply the aortic tissue. So bleeding happens, a hematoma forms inside the aortic tissue, and due to the high pressure, it bursts and causes an intimal tear, and that's the inciting factor for the aortic dissection. The last thing is the penetrating atherosclerotic ulcer. They think that a lot of dissections are caused of those because of these atherosclerotic ulcers, which mainly are plaques, atherosclerotic plaques that become ulcerated and penetrated into the through the intima and cause the dissection. Iatrogenic, meaning that dissection that are caused because of things that we do, either because of surgery or coronary angiogram or aortic instrumentation. It is interesting enough that 75% of aortic dissection cases, the mechanism in those are unknown. So for aortic dissection, we have high-risk conditions. High-risk conditions are conditions with where aortic dissection was associated with them with a very high rate, like hypertension or connective tissue disorders like Marfan disease, Ehlers-Danlos, and Lewis syndrome. Also, the bicuspid aortic valve, aortic instrumentation or surgery, like a history of aortic instrumentation surgery during investigation gives a higher likelihood for that patient to have an aortic dissection. Aortic coarctation, familial thoracic aortic aneurysm or aortic dissection, Turner syndrome, inflammatory disease that especially affect the vessels and causes inflammation of the vessels, trauma, pregnancy and delivery, interestingly, and medications. Medications like cocaine and amphetamine, these medications, they cause aortic dissection because they severely elevate the blood pressure, which causes hypertension, and it is one of the causes of aortic dissection. Also, I read that there are some case reports that with the use of fluoroquinolones, they found some cases of aortic dissections that were associated with the use of fluoroquinolones. For the pathophysiology of aortic dissection, it is due to abnormal media is the reason for the increased incidence of dissection. Once the cleavage plane is created in the media, the aortic wall that is floating, or what we call the flap in the lumen, is what causes most of the symptoms in the aortic dissection. The flap is mainly composed of aortic intima and partial thickness, it's supposed to be media, partial thickness media. So the primary tear usually happens in more than 50%, usually affect more than 50% of the aortic circumference. The most common location of the primary tear is on the right lateral wall of the ascending aorta. In Lawrence, I found that it says on the right anterior aspect, while this information and while reading and researching on the internet, I found most sources say that it's on the right lateral walls of the ascending aorta. The dissection can propagate retrogradely and involve the coronary ostia, the aortic valve, and the pericardial space and the aortic branches. So this is just a diagram or gram to show how the aortic valve can be affected during aortic dissection and causes aortic rigor. In the first image, it causes mainly dilatation of the aortic root. The aortic annulus or leaflet are not affected. And the second one, it causes asymmetric coaptation. It is affecting one of the leaflets. The last one, it is disrupting the aortic annulus, and that is the mechanism of aortic regurg, the aortic regurg in aortic dissection. To continue in the pathophysiology, the cause of death in 80% of acute dissection is mainly because of MI or acute rupture. The false lumen, it can have a communication with the true lumen. That's why when we leave the type B aortic dissection, most of the time there are no signs of malperfusion syndrome because both lumens are communicating and blood flows in both of them. The second one, it may end blindly in 4 to 12%. And the last one, that it may penetrate the adventitia and cause rupture.
يديك العافية.
So,
sorry for interruption. Just because you were mentioning about the most common sites, can you go back a little bit?
Okay. This is the slide of the most common
You
site.
mentioned the lateral wall.
Yeah,
the
right lateral wall.
Yeah, because what I know, it is the anterior, as you mentioned. So this information, you said you get it from the internet. So could you kind
from up to date?
In the up to date, but in the literature, what they mentioned?
I really did not review their source, but in up to date, it was mentioned in the right lateral wall. While in Lawrence, it was mentioned in right anterior. I looked in different articles. I don't remember them, but also some of them mentioned, but actually quickly, I did not spend a lot of time. They mentioned right lateral wall. Hello?
Yes, yes. So just to be with Lawrence for the time being, it's better because it is the textbook and it is the one recommended by Saudi Commission. But if we have like an articles from STS or the articles from the American Society, this is different story. This is why I just to emphasize points. Sorry for interruption.
No, it's okay.
Thank you.
You're welcome. So in an aortic dissection, usually the true lumen collapses and the false lumen dilates. That's what increases the aortic cross-sectional area. And the reason the false lumen size is affected by three things. The size of the tear, the larger the tear, the larger the size of the false lumen because more blood goes into that lumen, and the depth of the dissection because also it will contain more blood, and blood pressure because it is more stress force that will expand the false lumen, and the percentage of the aortic circumference involved. The true lumen most of the time is compressed by the false lumen, and that's due to the outer wall of the aorta expands to accommodate the aortic pressure, because the adventitia media are elastic and they can expand significantly with high pressure. So since the false lumen is in close contact with every beat, the false lumen expands and it gains more pressure that causes compression of the true lumen. The recoil of the dissection flap also exacerbates this collapse because during heartbeats between systole and diastole heart cycle, the flap is moving between the true and false lumen. And this recoil or movement also exacerbates the compression of the aortic lumen. I will show this dynamic of compression of the aortic lumen when we go into the imaging part. There are interesting videos. I hope I can show them and my internet does not collapse. So part of the pathophysiology is the organ malperfusion. And it happens when the dissection extends to involve branch vessels. It also happens due to compression of the true lumen by the false lumen. So when the true lumen becomes smaller, less blood goes into the distal branches. And also when the branch vessel could complete, the branch vessels of the aorta can completely be torn out of the true lumen and get malperfused or be perfused by the false lumen. And the false lumen could have no communication, so the blood will thrombose and less blood will go into that branch. There are two mechanisms for malperfusion in aortic dissection. We have the dynamic and the static. The dynamic, as I explained a while ago, it's with heartbeat. The false lumen, this is the one on the right side, the right diagram. The flap of the dissection moves with every heartbeat. So sometimes it goes into the branch and occlude it. So these symptoms could be intermittent, the symptoms of malperfusion. The static part is when the flap extends into the branch and occlude it completely. This is a static occlusion, and it logically seems even more dangerous and more acute. So this is a video of an MRI. I hope it works. If it does not work, I'll try. Yeah, just excuse me so I can share another screen with the video of this MRI. You can see the false lumen moving. Is the video showing?
It's showing it now. Yes, thank you.
Yes. Okay. So look at the right square, the right lower square, the right lower quadrant here. Look at, this is the dissection flap, and this is the true lumen. And see, these are branches, and with every beat, it is occluded. Of course, these are other views of this dissection, but here it shows clearly what I mentioned about the dynamic obstruction. These are branches and they are obstructed. I'll just repeat it one more time if it was not clear. So it's going slowly, I don't know why, but I hope the picture is clear. So we'll move now to the clinical presentation. For the clinical presentation, 40% of the patients with acute aortic dissection die immediately. 30% of the patients diagnosed to have acute aortic dissection are thought to have a different diagnosis initially. And this is very important, and we will talk about it in the next slides. Usually the onset of symptoms happen during the waking hours. They found in the International Registry of Aortic Dissection that most of the admissions of aortic dissection happen during the waking hours, between 8 and 12. And this could be because most of the physical activity happen in the morning, and that is accompanied by spikes in blood pressure, or maybe because of the different blood pressure readings between different times in the day. Usually in the morning it's higher when the patient's awake and with the daylight. So the most common symptom with aortic dissection is pain, and it is more than 90% of the cases. The pain onset is described as sudden, and its character as severe and unrelenting, and the patient will say that it's not similar to any previous pain that he had before. Also, it is described as ripping or tearing, and it is all usually constant, and it is greatest at onset. The location of the pain, it is variable, most of the time it depends on the location of the dissection, but mainly it happens in the chest, mid-sternum, or the abdomen, or on the back, interscapular. The pain can be migratory. This is due to propagation of the dissection. If it starts at type A and it starts as, let's say, type 2 DeBakey, and it ends up to be type B, from descending and propagate up until to the abdominal aorta. It can also be painless. Painless aortic dissection were described in the IRAD, and they usually happen in old patients and diabetic patients and patients with chronic aneurysm. Also in patients who have dissection post-cardiac surgery. The patients with painless dissection are usually older than 70-year-old. And this patient population composed of 1/3 of the IRAD aortic dissection population, which is a very significant fraction. 1/3 of the patients could have an aortic dissection without pain at presentation. Other symptoms and signs are malperfusion symptoms and signs, like neurologic. The patient could have loss of consciousness, He could have focal neurological deficit, either loose sensation or motion in part of his limbs, or one of the cranial nerves get affected. Visceral could be like an abdominal pain, a low urine output if the kidneys are affected. Limb ischemia could be claudication or change in the lower limb color or size. In the past history, usually patients report hypertension as a comorbidity. Some patients could have an aneurysmal disease of the aorta. Also, there is a family history of familial connective tissue disorders or dissections or aneurysms. Also, the history of illicit drug use, like drug abuser, patients who use cocaine and amphetamine with a drug overdose. They could have a severe spike in blood pressure and get an aortic dissection. Physical signs, usually patients come with tachycardia and hypertension. In case of rupture or tamponade or acute aortic regurgitation or acute MI, they could have tachycardia and hypotension. Pulse deficit, and pulse deficit is defined as a weak or absent either carotid, brachial, or femoral pulse. It should be more than the difference, it's absent pulse. There is also a variation in blood pressure, which we will come to right now. The variation in blood pressure needs to be, for it to be significant or positive finding, to have a systolic blood pressure more than 20 millimeter mercury difference between both arms, or between both arms, yes. Interestingly enough, it was found that pulse deficit was associated with mortality. This is a fact I found in UpToDate, that patients with no deficit were found to have 9.4% mortality within the 24 hours of presentation, while patients of 1 to 2 deficit have 15.8% within the 24 hours of presentation, and 3 or more deficits have 35.3 mortality rate, mortality within the 24 hour of presentation. On auscultation, you might find murmur due to aortic.
This finding. Your explanation of this finding.
Because more pulse deficit means the aortic dissection is more severe. It's affecting more vessels. So if the pulse is absent on the right and the left, it's affecting the brachiocephalic and affecting the left subclavian and also maybe the carotid, and so on.
Thank you.
Okay, so with auscultation, murmur is either due to aortic regurgitation or distant heart sound with the pericardial tamponade. For aortic regurgitation, it usually happens in 1/2 to 2/3 of patients with type A aortic dissection. Also, another auscultatory finding, you might have unequal breath sound in both lungs, and that might be due to hemothorax. The last thing is hypotension, which can happen due to tamponade or acute aortic regurg or acute MI. One fact is that the most common coronary affected in aortic dissection is the right coronary artery. Other neurological findings which can be found in patient aortic dissection, and neurologic abnormalities are found in 40% of type A aortic dissection, are syncope and stroke. And that happens mainly if the brachiocephalic vessels were involved. Syncope could not be because of neurologic abnormality. It could be a sign also of rupture in the pericardium and a tamponade. Stroke mainly happens in less than 5% of type A, and stroke rarely improves after treatment. But with that fact, stroke is not an absolute contraindication for surgical repair. Other finding is paraplegia and paraparesis, which happens due to malperfusion of the intercostal or the lumbar arteries, which lead to spinal cord ischemia. Other signs are like mass effect, like dysphagia or vocal cord paralysis because of compression on the carotid laryngeal nerve. Also other signs of organ malperfusion, like abdominal tenderness in case of peritonitis and bowel ischemia. Also, you can find in the lower limbs finding of limb ischemia. For chronic dissection, they usually are asymptomatic. Usually happen in patients with pre-existing aneurysm. That's why they were not detected at presentation, because as you remember, we said most of the some of the population that have painless dissection are patients with chronic aneurysm. Also, the presenting complaints of those patients are usually either intermittent or dull chest pain, severe skeletal pain from erosion of the bony structure by the large aneurysm, aortic regurg with chronic type A, or paralysis or paraplegia due to embolism from the false lumen. So this is a table I took from Lawrence, showing the difference between the two types of dissection, type A and type B. And you can find that the most common aortic dissection is type A. And it happens mainly in men, usually in elderly population. And you can review this on your own. It's describing how common are these symptoms or description of pain among these types of dissection. This is also a table that relates clinical finding with the structures involved in aortic dissection. So patients with aortic insufficiency or heart failure, usually the affected structure is the aortic valve. Myocardial infarction, the affected structure is coronary artery, which is often, as we said, the right coronary artery. Cardiac tamponade, the pericardium, and so on. Like you have here Horner syndrome, which is because of the superior cervical sympathetic ganglion in the aorta, near the aorta. So one of the things that makes diagnosing aortic dissection a very difficult and easy to miss diagnosis, even though it's life-threatening, is that its presenting symptoms are most of the time similar to other more common presentations, like acute coronary syndrome or PE, tension pneumothorax, tamponade, and mediastinitis. Usually happens due to esophageal rupture. Like the pain of esophageal rupture is almost exactly the same as an aortic dissection. So I advise you that there is like a table and up to date that summarizes how to differentiate between these differential diagnosis in clinical and laboratory and physical examination findings. For the diagnosis, there are multiple things multiple tools that could help you in the diagnosis. First, ECG. It is very unspecific for aortic dissection, but it can help you rule out other etiologies like aortic dissection, for example. But sometimes, sorry, not aortic dissection, myocardial infarction. But sometimes aortic dissection can present with the myocardial infarction. So ECG alone is not enough to rule out aortic dissection or to rule out myocardial infarction. Other things are laboratory tests. You can do tests to assess the end organ damage, like renal function, liver function, and also look for the levels of lactate to check for any organ ischemia. Another interesting lab test that you can do is the D-dimer. The D-dimer is a useful tool, useful screening tool, especially in ruling out aortic dissection. It's good to rule out aortic dissection, but it's not good to rule it in. The cutoff limit for a positive D-dimer result is 500 nanogram ml. It has to be more 500 nanogram. The sensitivity of D-dimer for aortic dissection is 97%. It's highly sensitive, but it is very, has a very atrocious specificity. It's 56%. And you can see the reason why on the right side on this table, showing you the disorders that can elevate the level of D-dimer. And you can find in the end why D-dimer is a good tool to rule out aortic dissection is because it's have a high negative predictive value. A very sensitive test and unspecific is a test that has a high net negative predictive value. And it is more useful when we combine it with the ADD-RS score. It stands for Aortic Dissection Detection Risk Score, which we will talk about in the next slide. One last thing to just show you how D-dimer is a good helping tool, but not something that you can depend on. In one study I read, it was found that 18% of patients with the aortic dissection can have less than 400 nanogram per ml of D-dimer. So as I said, it rules out, it is a good tool, but it's not a definitive tool. You need to have a high level of suspicion in order to, in addition to these tools. To these tools, we have also diagnostic imaging modalities. We can use the chest X-ray, echo, the helical CT, MRI, aortography, and IVUS. For the aortography and IVUS, I will not speak too much about them. Aortography is now obsolete for diagnosis. It's mainly used during endovascular intervention. And the IVUS is also the same. It is used while doing the endovascular intervention to just confirm the location of the graft and so on. I will be talking mainly about the chest X-ray, the echo, and the helical CT and MRI. For the chest X-ray, one important fact we need to realize is that normal X-ray does not rule out aortic dissection, because the abnormal chest X-ray is only found in 60 to 90% of patients with aortic dissection. The rest, 10% at least, have a normal aortic X-ray. But common finding that we can have in aortic dissection are either wide aortic silhouette, pleural effusion due to homothorax in 19%, displaced calcification, aortic kinking, and opacification of the aortopulmonary window. Displaced calcification, unfortunately, I don't have a picture here, but you can imagine the calcification on the aortic wall moving into the middle of the aortic lumen, because of the intimal flap, which has most of the calcification, moves into the middle after dissection, which is a sign, not a very specific sign, neither sensitive, but a sign that can be found in aortic dissection patients. In echo, mainly for the diagnosis of aortic dissection, we use transesophageal echo. It is the second most commonly used tool. It has a high sensitivity and high specificity. Sensitivity of 98 and specificity of 63 to 93%. It is the preferred tool when the patient is unstable at presentation. The diagnosis of aortic dissection is happening when you visualize an echogenic surface that separates the lumen of the aorta. And you have to see that in more than one view. The true lumen is identified mainly on transesophageal echo by first seeing it expanding during systole and collapse during diastole, and the continuity of, and you can see it, the continuity of the true aortic lumen with the left ventricular outflow tract. Also, in transesophageal echo, you can see the communication between the false and true lumen using color Doppler, and also a thrombus can be visualized in the false lumen during aortic dissection. For transesophageal echo, it can assess multiple things. It can assess the false lumen flow and the presence of thrombus, the entry site tear. It can assist for pericardial effusion. It is good for assessment of the arch and the coronary involvement. It can also assist the aortic valve function. The disadvantage, it needs sedation, and that sedation or the annoyance that happens to the patient due to introduction of the esophageal probe, it can affect the patients hemodynamically. And we don't, either by raising the blood pressure, which is very bad for patients with aortic dissection, or patients who are unstable by causing hypotension. Also, one of the disadvantages that transesophageal echo has a blind spot. That blind spot happens on the location of that blind spot is near the distal part of the ascending aorta and the proximal part of the arch of the aorta. And the reason for that is because of the right main bronchus is over these structures. And we know that air is the enemy of ultrasound. So that's why these structures are not accurately assessed by the transesophageal. Also, one disadvantage is the inability of transesophageal echo to assess the abdominal aorta. The contraindications for using the transesophageal aorta, the absolute is esophageal pathology. A relative is a full stomach. Ideally, you want the patient to be fasting. These are some of the images of the transesophageal echo of an aorta with an aortic dissection. You can see here the true lumen, and you can recognize it with the flow of the color Doppler flow. And here you can see the false lumen. Another finding that could help you also identify the false lumen is the thrombus here. Okay. These are also another images of the transesophageal echo. You can see them here. This is the true lumen and the false lumen. This is also another image. Here also an image of the true lumen and the intimal flap and the false lumen, and you can see the communication between the true and the false lumen. I think I have some videos of transesophageal echo. Just a minute, yeah. This is an image of transesophageal echo. You can also see the hemodynamic of the intimal flap on the transesophageal echo, how it moves. This is the true lumen and this is the false lumen with a thrombus. So also another modality we can use is the transthoracic echo. It's not the best, but it can be helpful because it's a quick and good tool to assess the ascending and aortic arch, and good for the assessment of the aortic dissection complication, like the aortic valve regurgitation or pericardial effusion. But it's not sufficient to establish a diagnosis of aortic dissection. The second modality we can use is the CT angiography. It's the most commonly used initial study. The best is the spiral or helical and ECG gated CT scan. And these additions, like the spiral, this technology, spiral and ECG gated, they increase the accuracy of CT scan because they reduce the artifacts because of either the movement of the aortic wall during systole and diastole. It was also good to assess for the involvement of the brachiocephalic branches. It is the diagnosis that in by a 96% accuracy. Disadvantages of CT is that it requires an IV contrast. An IV contrast is bad in patients with either compromised renal function or patient with coronary kidney disease, and it's also bad in case the patient has an allergy for it. Another disadvantage is radiation, and this is very important when you come to follow-up imaging. The patient will require multiple follow-up images in order to follow him up after treatment, and CT is very bad because CT, as you know, has a high dose of radiation. Another disadvantage is that the site of entry is rarely identified, and the flap is seen in less than 75% of the patients. The diagnosis is made on CT by identifying a dissection flap with two distinct lumen. The hints for false lumen on a CT scan are either you will see a thrombus, which is, even though it's a hint, but it's not always true that a lumen with a thrombus means it's the false lumen. Sometimes patients with aortic aneurysm could develop thrombus, and that thrombus you're seeing are the thrombus in the aneurysmal true lumen. And usually the false lumen is larger because, as we said in the beginning, it compresses the true lumen, the false lumen. One last thing is that when you do a CT scan for aortic dissection, you should also involve the whole aorta up to the iliofemoral vessels. And that is important for pre-op planning. These are images of a CT scan showing aortic dissection. Here you can see the intimal flap, and I suspect this is the false lumen and this is the true lumen. Here you can see another image of aortic dissection, but with a thrombosed. This is an intramural hematoma of the descending thoracic artery. So this is not a dissection. The thing, yeah, I remember now, the way you differentiate between a hematoma and an aortic dissection, here you cannot see an intimal flap and two distinct lumen. Usually you will be able to find the two distinct lumen, but this is an intramural hematoma, not an aortic dissection. This is another CT, but the difference is this one is not enhanced with the contrast. But this has an aortic dissection, and the finding is this calcification is in the middle of the lumen. It's the same thing you see in X-ray, but this one is found on CT. Like a displaced aortic calcification is another sign of aortic dissection. Another one of the imaging modality that can be used to diagnose aortic dissection is MRA, magnetic resonance angiogram, and it is as accurate as CT. Actually, it might be even better. It has a sensitivity and specificity of 95 to 100%. The advantages of MRA is that it has no radiation. It has a contrast, which is gadolinium, but it's less nephrotoxic than iodinated contrast used in CT. And it is also good and better, and it has the advantage over the CT that it can assist the LV function, the aortic valve function, the flow in the branches, and the false lumen. As we said, as we saw in the video I showed you in the beginning of that MRA of an aortic dissection flap moving. The disadvantages is that it's not available everywhere. And it's not practical. It has a very long time of study, at least half an hour for each study. And that is a very bad, especially when the patient is hemodynamically unstable. You cannot leave him into the MRI machine without the hemodynamic monitoring devices that we need, or the intubators. Also unlimited applicability. Patients who are claustrophobics, patients with metal prosthesis cannot have this imaging modality. This is an image of an aortic dissection and the aortic arch, showing the true lumen and the false lumen and the flap between them. So this is just a summary, a table summarizing the sensitivity and the specificity of the modality used for diagnosing aortic dissection. You can see that CT and MRI have the highest sensitivity and specificity, while the the transthoracic echo has a very low sensitivity and relatively high specificity. So now, in the last part about the diagnosis, we will go through how the algorithm or the mentality that one should undergo in order to reach a diagnosis. Aortic dissection, the first thing you need to have is a high index of suspicion. That's the best tool you can have for diagnosing aortic dissection. Because most of the differential diagnoses are very similar to the presentation of aortic dissection, and the management or treatment of these differentials, like the myocardial infarction, pulmonary embolism, are managed by things that could exacerbate aortic dissection, like MI and PE. We would manage them with the anticoagulation and thrombolytics, and these could propagate the dissection. So it's very important to diagnose an aortic dissection. So first you have to determine the likelihood of aortic dissection and whether the patient is stable or unstable, because that would affect the urgency of how you will tackle the case. So high-risk clinical features are typical pain with a probability of aortic dissection of 30%, 31%. So if a patient has typical pain alone, the probability of aortic dissection is 31%. If he had a pulse deficit, plus minus blood pressure difference, the probability of him having an aortic dissection is 83%. Mediastinal widening on X-ray has a probability of aortic dissection of 39%. A combination of any of these, like if you have two or if you have all of the three, the aortic dissection probability becomes higher than 83%. But let's say if you have none of them, the aortic dissection probability will be not 0, but 7%. So even if the patient does not present with any of these, he would have a 7% chance of having an aortic dissection. Okay, so for another tool that you can use in order to exclude or include aortic dissection is what we mentioned before, is the ADDRS tool, which stands for Aortic Dissection Detection Risk Score. It is based on the presence of one or more of the following: either a high-risk condition, which what we mentioned in the beginning, typical pain in the chest or back or abdomen, or a perfusion deficit. Perfusion deficit means pulse deficit, blood pressure difference. It includes also focal deficit, focal neurological deficit, aortic valve regurg, or hypotension or shock. The maximum score is 3. So for each class, you can have only one score, regardless of how many risk condition you have, or how many sites that have pain in them, or how many signs of perfusion deficit. And this is one of the things that people are criticizing about this score, that it does not take that into account. So if you had an hypertension and you are a Marfan syndrome patient, you will have only 1 point. While a patient with only hypertension, he will also have a 1 point. So in order to make this more accurate, you add it to the D-dimer score. There was a study called the ADVISED study. This study, they assessed this tool. And they found out that a score of 0 to 1 and a negative D-dimer. A negative D-dimer means less than 500. Rules out acute aortic syndrome with a failure rate of 1 to 300 patients. And also they found that if you have a score of 1 with a negative D-dimer, the sensitivity is 98.3 for aortic dissection, but a specificity of 57.3. So it can rule out aortic dissection. It's a good ruling out aortic dissection. What is better is if you have a 0 score with a negative D-dimer, the sensitivity becomes 99.6 with a specificity of 18.2. The thing about this tool is it's helpful, but I read that until now they've proven its internal validity, but its external validity, its generalizability to the population is still not proven. So it's another helpful tool that you can use. These are all tools you can use when the patient is stable. If the patient is unstable with a high likelihood for aortic dissection, these are tools you use to recognize who are likelihood patients and who are not a high likelihood patients. Because if the patient is unstable, you will not wait for CT or any test results. You will just take the patient in the OR. You will just stabilize the patient and send them into the OR and just do the intraoperative TEE to diagnose the transesophageal. If he's stable, and you can run your full assessment regardless if he's a high likelihood or a low likelihood. You can do history, physical, other lab work, and you can send them also for CT images. That concludes the first part. Before we move into the management of the aortic dissection, I will stop here for any questions or comments or addition. you are welcome to add. This is a very controversial topic, most of the research. It's mostly just descriptive studies, most of them, not even randomized, so you can add.
Yeah, I think I have it, Faisal. Can you go back to classification, please?
To what?
To classification, please.
Okay. The image or the text?
Text.
Okay. You mean this one?
Yeah. Yes. I think there is some class. I don't know exactly the source from up to date, right?
This these classifications, mainly you will see the chronological and the anatomic.
I mean, based on timing dissection, acute, and the chronic. I think there is other classification. The chronic is more than 6 weeks. Subacute from 14 to 6 weeks. I think this from American College of Cardiology. I think that, but in this classification, if you have the patient with the dissection more than two months, that means it's chronic.
More than 2 months, is he chronic or acute? I would say, according to this classification, he's subacute.
Subacute, but in the other classification, I think it American College of Cardiology or American Heart Association 2010, I think, or 2010 guidelines is a chronic, more than 6 weeks. I don't know exactly if anybody have some comments about that.
I reviewed the European, but it's the same. I don't remember.
Good afternoon.
Good afternoon.
Regarding the classification, the question Dr. Abdulaziz asked, the recent article was published by the Society of Vascular Surgery, Society of Thoracic Surgeon about the new classification of aortic dissection. This was in 2020. So they divided as hyperacute, acute, subacute, and chronic. Hyperacute, less than 24 hours, acute 1 to 14 days, subacute 15 to 90 days, and chronic more than 90 days.
هذه guidelines هذه ولا؟
What do you mean? This is a new articles by the Society of Vascular Surgery and Society of Thoracic Surgeons reporting standards for type B aortic dissection. And they mentioned type B and type A as well. The one I sent in the group, it was published, I think, 3 months back. They want to make it as a standard for all the society in the thoracic and vascular as well. This is the latest one.
Yeah, okay.
Dr. Haitham, you're right.
Even the European guidelines, European Society guidelines is said that chronic is more than 90. But my question about that, the guidelines from American guidelines, American Heart Association.
Yes.
Yeah.
This statement from Haitham is from the same organization, but it's more recent. So I think we should take the classification from the recent article from the SDS. And I think Haitham, this article was developed to solve this controversy in the classification. Am I right?
Yes, and also to address the problems of arch involvements. Dr. Shabir also want to comment. He was about to say something. Could you please pause?
No, yeah, Haitham, you're right. This is the latest article. I think we should follow that one now because the new classification and many things have been added in that classification. I would like Haitham, you circulate this article to everyone. And regarding the 6 weeks, 2 months, if you see the old surgical textbooks, it is written 2 months. Aziz is right in that way. You know, if you open the textbook like curriculum or something, or Prohan, I have read it long back, but it says like 2 months. You know, 14 days to 2 months, like that.
No, Dr. Shabir, it's based on a guideline, in American guidelines, 2010. But there is no any recent update from that. American guidelines.
Yeah, you are right, Aziz, but the latest article is very nice. I think you should go through it. What Haitham was mentioning about it. It has done lots of new classifications, you know. It includes the type B mostly. If you see the type B mostly is type B, but a nice article, yeah. But still, it is not a. I mean, not a too much, the days or something. I think just know about there is a chronic, there is acute. You know, it is not a big deal. But I think, but Aziz, just go through new article. Very interesting article. Yeah.
Okay. Yeah. Thank you, Dr. Thank you so much.
Right. Yeah. Very nice article. You will enjoy. Everyone, you will enjoy reading that. It's not long article. The one I sent in the group.
Thank you. Thank you.
Could you continue?
Okay. So I will start with the second part, and it is the most. It's a part with it was the most difficult part actually. It's not the management mainly. It's actually the medical management. Actually, that's the surgical and invasive interventions, and which I will need your help, and where discussion I think would be more beneficial. So you are welcome to add whenever you want. So for the management of type, I will start type A aortic dissection. Patients who are, first you have to categorize the patients. Either the patient is unstable or stable. If the suspected cases of aortic dissection is unstable, if he's a high risk likelihood, as we said, you should take him to the OR immediately and do your transesophageal echo, and it's an emergency, a surgical emergency. He has to have undergo a surgical repair. If he is stable, then you have a time to do your detailed investigation. But the patient has to be managed in an acute care setting, in an ICU, where he can have an intensive monitoring. The reason I'm saying that is because 50% of type A patients will die during their hospitalization if they are not treated. And for each hour the patient spends while being misdiagnosed, there is a 1% mortality rate. So for the patient, for each hour he's not diagnosed or not managed, he has a 1% more of mortality rate. It was found in the International Registry of Aortic Dissection that patients with type A who were managed medically because of they were deemed high risk for surgery, that 58% had an in-hospital mortality during their admission. So for the initial medical management of patients with type A aortic dissection, as we said, in a stable patient, in unstable patients, you will transfer him to the OR. You will anesthetize him first and stabilize him and intubate him. Do your transesophageal echo and insert your central lines. And once the diagnosis is made, assuming that he's in aortic dissection, you should prepare for OR for repair, or if the patient is in shock, for the decompressive pericardiotomy, or connect the patient, initiate bypass for the patients, because before the patient had a rupture or hemodynamic cardiac arrest. For a stable patient, as we said, you would transfer him to the ICU, connect him to intensive monitoring, and start what is called an aortic dissection anti-impulse therapy and also pain control. These are the two modalities for medical management in both type A and type B. For the anti-impulse therapy, the goal is to reduce the shear stress on the aorta, because high wall stress increases the chance of rupture. The shear stress is reduced by minimizing the rate of rise in aortic pressure. And this is done by lowering the blood pressure and heart rate. Usually the target for systolic blood pressure is between 90 to 110. Sometimes they found between 80 and 100, and the heart rate 60 or lower than 60. The two classes of medication that that are usually used are beta blockers and peripheral vasodilators. Beta blockers, usually you should start administering them first before the vasodilators, because vasodilators will cause reflex tachycardia and increase the heart rate, and which will increase the chance of rupture. And usually you would start with the ideal beta blocker agent is an IV agent, short acting, with a short duration. So in order for you to titrate it to the desired heart rate. For example, we have esomolol, propranolol, metoprolol, and labetalol. Peripheral vasodilator, sodium nitroprusside can be used. They are a direct arterial vasodilators. They have a fast onset and a short duration. Calcium channel blockers also can be used, especially in patients who cannot tolerate beta blockers. One remark about the beta blockers. As you remember, some of the patient aortic dissection are patients with cocaine or amphetamine abuse. So you should be careful using beta blockers in such patients with cocaine overdose. So, as we said, aortic dissection is a surgical emergency. As you see here on the table from the book, type A indication for surgery is just the presence of acute type A dissection is just an indication for surgery. So the goals for surgical management of acute type A aortic dissection is to restore the blood flow to the true lumen, and also to prevent aortic catastrophes like rupture or occlusion of the coronaries or progression to aortic valve incompetence. Factors that need to be taken before taking the patient to the OR are first the age of the patients. As we said, age is not an absolute contraindication for surgical intervention, but it has to be taken into account, especially when you know that more than 8 patients who are older than 80 usually have worse outcome than any other patients. Also, the neurologic status. Patients who are obtunded or comatose or have a stroke are unlikely to improve after surgical intervention. But as we said, it's also stroke and paraplegia are not a contraindication for surgical intervention. The third thing is thrombosis of the false lumen. Let's say you found a chronic aortic dissection type A, and you found the false lumen thrombosed. That doesn't mean it no longer needs an intervention. It needs repair, regardless. Subacute type A presentation, some will argue that those patients survived the first 14 days in the most acute, and now they are alive, so why would we risk the surgery? They will also need a repair, even though they survived. Actually, they are better candidates for surgical repair, because since they survived, they are more fit for the surgery than the patients who met their demise in the acute phase. So in order to decide the surgery, you need to plan for the surgery. You need to know the extent of the repair you will undergo, what type of anesthesia, your cardiopulmonary bypass strategy, the kind of cerebral protection you would use, myocardial protection. Also, if the aortic valve is involved, what will you do regarding that? And also organ perfusion management. So first, the extent of the repair. The repair procedure will differ depending on what parts of the aorta will affect it. Since we are speaking with type A, we know for sure the ascending aorta is affected. But if it's only the ascending aorta, you would just repair that with a graft. But if the aortic, if the dissection propagates retrogradely into the aortic root, then you would have to do a root replacement. If it affects the valve and causes a regurg, you will see the kind of dysfunction that happened, the kind of mechanism of regurg. Is it because of, is it the valve and the annulus are not affected and intact? Then you would do a valve sparing. If they are affected, then you would do a Bentall procedure, composite graft Bentall procedure. Are the coronary ostia affected or not? Also, if the arch is involved or not. So these things you need to know before you go to the surgery, and you need to plan your repair. For the anesthesia, usually it is general anesthesia using a narcotic-based and an inhalational agent for maintenance. Usually endotracheal tube is used for intubation. Single lumen mainly used for median sternotomy approach. Double lumen when you will go through a thoracotomy approach. The monitoring line usually needed are central venous line, pulmonary artery catheter, arterial line, either 1 or 2 radial, and at least 1 femoral, to monitor the perfusion in lower and upper limb. And also, if you plan to use an antegrade cerebral perfusion, you will need a right radial, right arm arterial line to monitor the perfusion pressure. The Corbett, yes, you can.
Why you mentioned the double lumen intubation?
In case if you will, your incision will be a thoracotomy.
Why you will do thoracotomy for type A?
Thoracotomy to access the descending thoracic aorta.
No, wait.
No, type A. لا في يعني فيصل type A it's only the ascending. You don't need the thoracotomy.
Type A can extend to the descending.
Type, if it is extend, what you will do? Tell me now.
If let's say he's a Marfan patient.
Okay, I will give you a scenario. Sorry, Hussein, for interruption. So I will give you a scenario. You have type A involving the roots, ascending aorta, all the arch, and descending aorta. All dissection. Why you want to do thoracotomy?
Thoracotomy, if you will do
فيصل الثوراكوتومي هذه ممكن تسويها عشان قصدك لما يكون stages, بس stages you will not do it now. Now you will deal with the ascending and leave the descending later. يمكن تسويها تحط stent, ممكن elephant trunk. There is different approach, but now your aim is just to manage patient as emergency. You fix the ascending, you fix the ascending and leave the rest later.
Okay, because it was mentioned, I wondered
and
why.
There's a time that it.
Over Dr. Farid.
There are occasions where you have to go for the thoracotomy first, knowing the fact that the patient have a type A dissection that goes all the way across type 1. Type 1 dissection which goes all the way across. And that occasion and that occasion can be when you have a patient with ascending involvement, arch involvement. The origin is in the ascending, but the main pathology now, the patient presenting now with rupture of the descending aorta. So you have to open the chest as well as at the same time you address the heart. Rare occasion, yes, but it can happen. So what Faisal mentioned may be required, and you have to be aware of it.
Thank you. Very clear.
Okay.
Okay.
So in that case, Dr. Farid, you will replace the whole aorta in the first operation?
It has been done. If you can avoid it, it's not recommended. But if you kind of what one can do is also entertain these days the endovascular repair.
Yes, thank you.
So you can attempt, sometimes it's feasible that you have a landing zone and you have a good area where you can plug the graft in temporary until you hold the issue of ruptured descending, and go for the ascending with elephant trunk, and then come back 6 weeks later and try to fix the descending part, either again by endovascular or by open. It depends on what you have pathology at that time. But not all cases are amenable to this kind of approach, and you have to be versatile. يعني تخلي عندك flexibility. Yes, I can go to the extreme. I can open the patient right and left and يعني do the massive procedure, and you'll have a major complication, major mortality rate, but sometimes that's the only way you can do it.
So shall I continue, or any addition?
Yes, please continue.
Okay. So to add to the anesthesia monitoring part, you will need to monitor the core body temperature. Usually this may be done by either a Foley cath probe or a nasopharyngeal probe. Also, you will need the neurologic monitoring. There are multiple devices that can be used for neurological monitoring. You have the transcranial Doppler, which can be used to identify a malpositioned cannula, cannulas for the antegrade or retrograde, antegrade cerebral perfusion, or to document the need for adjustment of the retrograde perfusion. Also, there is the near-infrared spectroscopy, which monitors the cerebral oxygenation, and it is good to identify regional changes in oxygenation during the operation. It is useful during normothermic periods, because during a hypothermic period, the vasculature, I think, will be constricted, and there will be no blood to be detected with this sensor. Somatosensory evoked potential. It is a modality used to identify injury of the peripheral nerves and also the brain. It can identify the injury even during deep hypothermic circulatory arrest period, and even before finding an abnormality on the EEG. Also, another modality that can be used is the EEG, and the only thing I know about the EEG is to know when is the temperature, the correct temperature for electrophysiologic silence to start your circulatory arrest. Am I correct, or do we have other uses for EEG?
Yes, this is the gold standard to check for what do you call it, to decrease the metabolism of the brain to the minimum to go into respiratory arrest.
When you say the gold standard, what do you mean by that?
I mean, when they build the new technologies to check for the metabolism of the brain during hypoperfusion state, they use the EEG as the gold standard to compare it with.
So routine arch surgery, hypothermic circulatory arrest, do you routinely use EEG?
No. I didn't say they use it routinely in clinical practice. When we say a gold standard thing, we mean that this is the thing that we use to compare any new technology, anything new to know how does it work comparing to this gold standard.
I think the gold standard means it's the most accurate thing to use.
Yes,
so
it is supposedly it's the most accurate, so that's why we call it the gold standard. But it doesn't mean that it is the most commonly clinical thing to be used. For example, if we want the most accurate test for the internal diameter of the aorta, for example, we would say it's the aortic angiogram. but it's not it is not the most
Most
practical,
common
the
way to.
recommended. Yeah, this is what I mean.
Okay.
Okay, so also an important part that you need to plan for during your procedure is hemostasis. In this procedure, blood loss is common because of weak tissue and also coagulopathy. Coagulopathy caused by either the hypothermia or the bleeding. It is usually managed by using a cell saver, preparing blood products in advance, using antifibrinolytic agents, and also use of hemostatic materials like the fibrin glue, Surgicel, and gel foam. Also, your cardiopulmonary bypass strategy is something that you need to plan. For like venous cannulation, you have the option of either a bicable or a dual stage or two-stage venous cannula. And the two-stage venous cannula has the advantages when you're doing a retrograde cerebral perfusion. It would be useful because you will just use the SVC cannula. Sorry, I meant the bicable, the SVC cannula directly to do the retrograde cerebral perfusion. Am I right or wrong?
So you are now cardiopulmonary bypass strategy, venous cannulation, either it can be bicable, so that even will help you in if you want to do retrograde cerebral perfusion. So at that time, you need to have it as bicable. But before going to that area, from the beginning, the most important things is you review the patient, the imagings before you are going to the operation, to the operating room. So at that time, you have full planning what you will do. For example, you will do axillary or you will go with the femoral one. You will do it central cannulation, for cannulation or peripherally, and which type of peripheral cannulation you prefer. Axillary cannulation has advantages of give you an access to do an antegrade cerebral perfusion while you are in hypothermic circulatory arrest if you are doing the hemi-arch. But in example, if you have a cases or you are not expert to do that, or you have a case that is there is no benefit to do axillary cannulation, like in case of apparent subclavian vein. So in that case, it will not differ if you do axillary or you do femoral. It happened with me twice in two cases.
هيثم انت قلت subclavian vein.
Apparent right subclavian vein, yes. Apparent right subclavian.
You mean artery?
Sorry, artery. Sorry. You're right, Hussein. Sorry. Thank you for correcting me. One case.
لا لانه المشكله هنا انه فيصل قاعد يتكلم عن الفينوس كانيوليشن. فانت رحت السبكليفيان.
Yeah, sorry, my mistake. I'm now going from venous, arterial, everything, because you need to have a plan before you are going. I remember one case with Dr. Shabir. We did it, I think, in early morning. Patient was with the right apparent subclavian vein. So we cannulate the femoral at that time, and then a central cannulation central cannulation was we didn't use an auxiliary. We didn't use an auxiliary cannulation. Usually, even Dr. Shabir is almost all the time he uses an auxiliary for the help of if we need circulatory arrest for the hemi-arch for antegrade cerebral perfusion. Also, you can use it selectively if you want to do that. There is a special cannula for selective antegrade through arch vessels. However, sometimes you don't have that. You don't have that cannula. So a trick I learned from Dr. Nadir, you can use, the cannula of retrograde for retrograde cardioplegia cannula that you inserted in the coronary sinus. You can use it, inflate the balloon, and snare directly and put it to the neck vessels while you are doing your repair. So why I mention all that, it's you need to plan before you are going or opening everything. or you can, and also to use antegrade or retrograde. The advantages that I see to use the bicable if you are planning to do retrograde cerebral protection. If anyone want to elaborate more on this point, please.
So, يعني, what Faisal mentioned before, standard, it's central cannulation for the venous, unless you want to go on bypass before opening the chest, you will do peripheral cannulation for the venous.
Yes. But if, venous, you can do it central, but for arterial, either you do axillary, if you have extensive dissection. So the option you have peripheral, or you have either peripheral cannulation or by the assistant of TEE and HEL, you can do direct cannulation through true lumen, central as well, for the arterial, I mean.
I think the stability of the patient will play a major role in the cannulation decision. For example, if we have a dissected patient, but in relative stable condition, has stable hemodynamically and so on, for this patient, I think the most common cannulation strategy would be the axillary cannulation for the arterial and bicable central cannulation for venous. But for example, if we have a patient with impending rupture or already ruptured, for this patient, I think you would like to cannulate peripherally through venous arterial, through femoral venous and arterial cannulation, and go on pump before you open the chest. For some patients, also I read about some central cannulation strategy where you can cannulate through the ascending aorta itself. With the samurai technique, they call it, where you open and go put your cannula in the true lumen, or in the most extreme cases, you can go through the ventricular apex and to be 100% sure that you are in the true lumen of the ascending aorta.
أو إنك مرة تسوي سيلدينجر تكنيك، إنك تحط جايد واير through the true lumen. samurai technique I think دكتور فريد يسويها.
Okay, let me ask you this. It's interesting that you have mentioned all these techniques. How many of you, can you please say your name, if you were involved recently with an acute ascending arch dissection? So none of you have been involved with acute dissection?
Well, not whole arch. Actually,
Again, دكتور فريد أنا ما سمعت السؤال.
The question is, this is a type A dissection or one or two DeBakey, which involve the ascending and the arch. Okay, so you have to go for circulatory arrest in this patient. Now, such a patient, have you been involved recently with such a patient? Not recently, through your 7 years program.
I was involved recently in one patient.
Okay, who else? That's fine. Who else?
Me.
أنا بعد.
يا أخي قول اسمك لو سمحت. سعادة الوزير.
مو معروف. ها شفت عرفت أنت سعادة الوزير على طول.
طيب هذول الثلاثة،
الله.
في أحد ثاني غير هذول الثلاثة؟ طيب شو اسمه يا حسين, what kind of cannulation did you do for that patient? Was he stable or unstable, and what kind of cannulation did you do?
Most of them they are stable.
لا ما ابغى اقول most of them, اقول لك انت ايش بتسوي هناك.
لا most في اللي انا شفت يمكن 5 أو 6.
كويس.
Most of them كانوا stable. We did axillary cannulation and double stage venous cannulation.
Okay, so خلينا نقول 4 مثلا من ال5 هذول axillary cannulation.
5 من ال6 اي.
طيب يا هيثم.
وواحد منهم سوينا femoral cannulation.
طيب يا هيثم.
Okay, the patient actually was stable, but his anatomy, he had the right upper and subclavian vein. Sorry, artery, right upper and subclavian artery. So we cannulated, actually I opened the chest, Dr. Nadir was with me, he cannulating the femoral. Then we went on pump, arterial was arterial in the femoral artery, and the venous was in the right atrium. This was
Khalid.
most of the
الوزير.
patients يعني اهلا سعاده الوزير انا اغلب المرضى اللي شفتهم كلهم axillary cannulation and right atrial double stage except one patient that we did central cannulation. We did not use antegrade perfusion in which this patient had a stroke, a massive stroke. But it wasn't a good idea to not start to just depend on circulatory arrest alone in protecting the brain. فموست اوف ذا يعني مو موست كل الكيس اللي شفتها كانت axillary cannulation and right atrial double stage cannulation.
طيب أنا يعني if you survey many of the centers until today, the most common type of cannulation will still be femoral, and they will use central cannulation for the venous with retrograde or antegrade for the brain. Antegrade can be initiated directly into the innominate artery. But the best, according to the literature, the best approach is the axillary. And that's why you find probably most of the, not junior, but most of the, the current young surgeon are the ones who are using the axillary artery. هذا يجاوب لك السؤال يا مرتضى أو الاستفسار اللي عندك؟ طيب شكرا.
دكتور عندي سؤال.
Yes, Dr. Ferry. I use most of the time I use axillary because as was mentioned before, a resident, they are stable usually unless we have an unstable patient. Most of the time I do axillary. I give an antegrade and a unilateral. I don't give double, always single side. So the right sided only. I remember just one case where I have to go to femoral and I put a bicaval and give a retrograde cerebroplegia. Otherwise, I prefer to the right axillary.
Commenting on what you said, Dr. Shabir, they did a study comparing bicarotid antegrade perfusion in which they were cannulating the axillary, and once they opened the arch, they put a Foley catheter or any retrograde perfusion cannula in the left carotid, and they perfuse both carotids. And interestingly, they find that the patient who had bilateral carotid perfusion, they had higher rate of stroke. They rely this maybe due to instrumentation and manipulation of the left carotid that may cause the stroke rate to be higher. So the message at the end was unilateral carotid perfusion was enough, although there's around 50% to 20% of patients that they don't have a complete circle of Willis. Thank you.
Good, thank you.
Doctor, I have one question. Regarding the femoral artery cannulation. Is there a risk of retrograde propagation for aortic dissection?
جاوب حسين.
Maybe, but you have to make sure you are cannulating the right one. Most likely will be the right side free of dissection.
Okay.
But this is not solid rule. You have to see the CT scan.
What other technique?
But it can be propagated.
Okay. What other technical things that you do to prevent retrograde propagation?
Lowering the pressure and flow rate prevent?
Well, but you have limitation there. Most importantly, as you do it, not only being on the right side, but make sure you're on the true lumen.
But there could be communication, right, between the false and the true alongside the.
And that's mean most likely will be no propagation because you already have a vent for the lumen. But hopefully you're not in the false lumen. مهم جدا تفتح وتشوف وتتأكد. You make sure that you see the intima clearly.
Thank you.
شكرا.
So for, as we said, Dr. Haytham mentioned almost everything regarding cardiopulmonary bypass strategy. But to summarize, in the venting, you have, it's important, especially when you have aortic valve insufficiency. You can do it through the right superior pulmonary vein or the left ventricular apex. Cardioplegia, you can do it either ostial, directly into the coronary ostiums, or retrogradely through the coronary sinus. For the arterial line, you have to
معلش فيصل, Dr. Farid, you are using vent routinely in these cases?
No, I give the cardioplegia until the heart fibrillates. If the patient has significant regurg, he will refibrillate early. And then I stop the circulation momentarily and clamp with the dissection the area leaving the forward flow through the axillary or through the femoral, and deal with the heart separately with direct cardioplegia into the heart.
Mm-hmm.
For the arterial lines, you have to make sure that to perfuse the true lumen. Also, you have to make it a habit to always monitor the end organ perfusion throughout the procedure. Multiple sites of arterial cannulation could be used if required. The decision is made based on the anatomy of the dissection first and the surgeon's preference. Possible sites are femoral artery, the ascending aorta, right axillary artery, and the innominate artery. For the cerebral protection, there are some principles that need to be considered. While on the cardiopulmonary bypass, the maximum temperature difference between the perfusate and the patient should be less than 10 degrees Celsius. The head should be, I don't know if this is a must. The head should be packed in ice to maintain low brain temperature. I don't think this is a must for all cases. Am I right, or is this a necessary thing?
No, you need to do that.
We need to do that in each deep hypothermic circulatory arrest case.
Why?
So the idea is to prevent rewarming after you go on, because when you will cool the patient while you are still on the pump, right? But once you are in circle rest, there is no blood running around to cool the patient. You are depending on I don't know what they call it, the external
I got
or something, and you got
مرتضى.
yes.
في نوع عندك يقول لك hypothermic with يعني antegrade cerebral perfusion with moderate hypothermia. تمام, and they found some advantage in this. So sometimes you don't go even to 18. Sometimes you go to 24 or 26 sometimes, and you go circulate arrest. Then you start antegrade cerebral perfusion. In such a situation, you may not need to put ice pack around the head. And already you're perfusing the brain continuously with your antegrade cerebral perfusion. تمام?
You mean if we use an antegrade or retrograde cerebral perfusion, there is no need to use.
You are giving the brain blood, and you are maintaining the pressure that you want.
Yeah, but if you are just using a circulatory arrest, I think it's
if it's circulatory arrest alone without antegrade cerebral perfusion, this is a different story.
Yeah, to prevent rewarming of the brain.
Yeah, but if you give antegrade cerebral perfusion,
no need.
This is different. Yeah.
So, Murtada, you have a patient with hypothermic circulatory arrest with antegrade perfusion.
Yes.
How would ice packing help this patient?
Well, even if we are using antegrade perfusion, the idea is the same. As we go low on the temperature, the metabolism will go lower. So we will need less flow through antegrade. Less flow means less complications in regard of all complications of high flow. So I think this is one advantage.
So actually, Khalid, yes, we use it all the time. And the main reason is that we cannot guarantee that every time we're going to have a smooth procedure with no problems. Sometimes you have dissection involving the innominate, or you may have to stop the circulation for some reason or another. You may have major problems with the pump.
Incomplete circuit fullness.
Yeah. Well, the problem have a problem with the pump, or the perfusionist, or something bad happens, and you have to stop the circulation. Having packs around the brain, around the head, may give you that extra few minutes to protect the brain. So yes, we may not need it, but it's not going to be harmful. It's not harmful to put it, and we have used it all the time. And anytime we use circular arrest, including those we use antegrade perfusion. Thank you.
So to achieve maximum protection, the goal temperature should be maintained for 5 minutes before starting.
Just can I ask one question, Dr. معلش فيصل قاطعك. فريد.
يا حبيبي.
Are you using a deep hypothermic arrest in all cases, ولا sometimes you go with moderate, which is around 20?
Okay, we used to go down to 15 degrees as a rule. First, in the beginning, we used isoelectric activity as our mark. And we found many of our patients somewhere around between 15 and 18 degrees, they have isoelectric. So we stopped using the isoelectric and we just go blindly to 15, 16 degrees. But as we use the antegrade, we have changed our strategy. We changed now to somewhere between 20 and 22. We keep the patient at that. Once we reach that, we do the circulatory arrest, but we continue the procedure with moderate hypothermia. Moderate hypothermia, you have to specify what, because even with the cardioplegia, we have changed moderate hypothermia from deep hypothermia 25 to 28 to 32, and now we call 28 to 32 moderate hypothermia for the cardioplegia. For the brain protection, which we call it as cerebroplegia, we use 20, 22 in that range.
طبعا تاكيد على كلامك دكتور انه لانه في ريسنت ميتا اناليسيز اللي compared المودريت hypothermia with the antegrade perfusion comparing to deep hypothermic circulatory arrest. لقوا انه طبعا المودريت hypothermia they are less in permanent neurological deficit اللي هي stroke or coma. Although there is no difference in mortality ولا في بسوانة انه هو temporal neurological deficit. طبعا الكواجلوباثي عارفين احنا دي hypothermia كل ما زودنا كل ما صارت شو اسمه الكواجلوباثي inflammatory response in organ dysfunction اكثر. That's why people they tend for moderate hypothermia with antegrade cerebral perfusion rather than going to the old school with the 18 or 15 degree. شكرا.
Okay, so one question.
Dr. Khalid. Dr. Khalid, there was a difference in minor neurological deficit, you said?
الديفرنس ما كان في الماينور، كان في البيرمننت نيورولوجيكال ديفيسيت كانت لور. الماينور والمورتاليتي بشكل عام ما كان في فرق.
Okay, but in term of major strokes, there was a significant difference between moderate hypothermia
إنك تحط moderate hypothermic circulatory arrest with antegrade comparing to deep hypothermic circulatory arrest alone.
ما قالوا ليش يعني maybe due to over rewarming ولا something like this.
ممكن إنه طبعا over rewarming whatever بس I'm not sure ما في سبب معين يعني.
Thank you very much.
One question, what is permissive hypothermia? Hello?
Permissive hypothermia?
Yeah, it's a term that I...
permissive, أنا what I know. طبعا أنت عارف إن المريض لما يكون على البايباس and you have to, you have to control his temperature actively by the heater water cooler يعني. ما هو sometimes you hear the term just drift ولا عرفت الأشياء هذه when you just go on bypass and you don't يعني warm the patient by default his temperature will go down لأن تعرف الenvironment اللي حولي كلها أنت is cold, is not like 32 cold temperature عرفت أو 37 حقت البيشنت. Once you go on bypass and you don't warm the patient by default will drop to 32, 20, 28, whatever. That's why sometimes you hear يقول لك والله drift. Shall I cool? يقول لك only drift. فانزل شوي، عرفت؟ this is هذا اللي افهمه هنا لما تقولي permissive hypothermia.
allow
otherwise
the patient to cool.
ايوه بدون ما هو يعني ما هو يعني ما هو active cooling، عرفت؟ ولا active rewarming.
تمام.
ما ادري اذا كان هذا صح، هو نفسه التعبير اللي هو دريفت زي البريمسيف هايبوثيرميا ولا لا؟ ممكن الدكتور فريد بعد فيها شيء ثاني.
No comment.
Okay, so to achieve maximum protection, the goal temperature should be maintained for 5 minutes before starting circulatory arrest.
بروفيسور معلش بس بقطعك ثواني. كم تتوقع يبغى لك اساس السيشنز الاخيره؟
Maybe it depends on the discussion, but maybe half an hour or an hour.
طيب هي الاخيره جايد لاينز المفروض تاخذ حوالي 20 minutes. I think يعني half an hour is good بس maximum.
Okay. Inshallah, I will try to finish fast. Rewarming should be up to 37 degrees because the body temperature usually falls after cessation of rewarming and discontinuation of bypass. So cerebral protection, there are different means we use for cerebral protection. First is deep hypothermia. The second thing is continued perfusion during circulatory arrest and pharmacologic adjuncts. For the deep hypothermia, there are two primary endpoints when cooling a patient, either use the temperature as an endpoint or EEG silence. If you use the temperature, you have to aim at a temperature between 14 and 32. And it was found that for the temperature less than 14 degrees can lead to non-ischemic brain injury. Straight hypothermia time should be short, as short as possible, no more than 20 minutes. The EEG silence, if you use it as a primary endpoint, once there is silence, cooling and circulation are stopped. Silence usually happens at the temperature between 15 to 22. For the continued perfusion, used when circulatory arrest duration is more than 20 minutes. When used, a moderate hypothermia can be used. That means between 24 and 28 degrees Celsius. You have two methods, retrograde and selective antegrade cerebral perfusion. There are no differences or proven evidence that there is an advantage of one over the other. But the difference is that retrograde depends on the venous cannulation method that you use. And its advantage is that it washes out debris and air out through the brachiocephalic vessels. The flow rate at the SVC pressure needs to be 15 to 25. The selective antegrade cerebral perfusion is a good option, especially when an extended aortic repair is planned. Can be done unilaterally or bilaterally. The pharmacologic adjuncts, you have multiple, and they are believed to decrease the metabolic rate, in which it will decrease the injury. Agents are like methylprednisolone, lidocaine and magnesium, and furosemide and mannitol. Also, I read that in order to protect also the spine, descending thoracic aortic surgeries, for example, they use sometimes intrathecal papaverine. So the operative techniques for type A, first you need to have a proper exposure, and to access the ascending aorta and the aortic arch, usually you do that through a median sternotomy. It can be augmented through a supraclavicular or cervical incision to access the brachiocephalic vessels, or a trapdoor incision to access the descending aorta. Important structures to be wary of are left vagus nerve and its branch, the recurrent laryngeal nerve, and also the left phrenic nerve. These can be injured while dissecting around the ascending and the aortic arch. To replace the ascending aorta, there is a technique called open distal anastomosis. This is best for ascending aorta replacement when the arch involvement is 30% or more, or the extent of the dissection into the arch is unknown. The steps are, first you have to do you have two scenarios. Either you can clamp the aorta or you cannot. If you can clamp the aorta, and I will mention that, I didn't want to write it because it will be very long. You first start your cardiopulmonary bypass and put your plegia catheter in place. You would clamp the mid-ascending aorta and administer plegia and arrest the heart. Once you do that, you dissect the ascending aorta and you open the open proximal to the clamp, opening the ascending aorta proximal to the clamp. At that time, while you are cooling the patient, you will evaluate the aortic valve, and if it's affected, you can repair it or you will decide to replace it. And then you would evaluate also the root. If it's not involved, then the aorta is resected 5 to 10 millimeter above the sinotubular junction. If it's involved, you would replace the aorta. The aorta replacement procedure is the modified Pental procedure, where you would replace the aortic. Actually, there are multiple. The modified Pental procedure, if I am not mistaken, is when you replace with a composite graft the aortic root and the valve. If the aortic root the aortic valve is like intact and doesn't need replacement, you would do aortic valve sparing root replacement, either the David or the Jakob procedure. The David is when you create new sinuses and the edge of the aortic root graft will be by the annulus of the aortic valve. And the Jakob is when you fashion sinuses and attach them to the valves without them being attached to the annulus. So after doing that, and while doing that, systemic cooling have taken place and you have reached hypothermia, which is between 18 and 21 degree, you would start your circulatory arrest, start cerebral perfusion if you anticipated a prolonged repair. And then you would release the clamp and assess your arch. If the arch is not affected totally, you would do a hemi-arch replacement. I have images I will show at the end. Or if the arch is affected, you will do a total arch replacement. And the way you will manage the brachiocephalic vessels, if they are not affected, you would implant them as an island. You would take them all as a graft and implant them onto the vascular graft. And if the vessels are affected by the dissection, you would fashion a graft for each vessel and then anastomose them to the new vascular graft. If the aortic aorta cannot be cross-clamped, you would cool the patient first until he fibrillates. The LV then will need decompression because of fibrillation and there is no venting. So we will need to work quickly to prevent LV distension. So once the LV fibrillates, you would do circulatory arrest, and then you will first, in this method, you will start first with the distal, because to shorten the time of circulatory arrest and to provide distal perfusion after you finish the distal, and then you will start with the proximal, the same as we mentioned, by assessing the aortic valve and the aortic root involvement. This is also another way of replacing the ascending aorta. This is the hemi-arch and the total arch replacement. These are images depicting what I mentioned. The first one on the left, this is an aortic root and an ascending aorta replacement. From this image, I can deduce, I think, is that it is a David procedure, because it seems like it kept the aortic valve in place. And it involved even the annulus of the aortic valve. The one on the middle, it's an ascending with hemi-arch replacement. The one on the far right is an ascending with full arch replacement. And with the specific grafts. This method has a name, but I actually forgot it right now. If the aortic root is involved, as I mentioned, you have the David and Jakob. I have actually a video, but I don't think we have a time to show it, explaining what I just mentioned. If the aortic valve is intact, you would just spare aortic valve sparing root replacement. If it's affected, you would either repair it, and I don't think this is done anymore because I think this has a higher risk of aneurysms later, or you would replace it using a composite graft like the Bental procedure or a homograft or a Ross procedure. The way you will deal with the coronary artery, it depends on their involvement in the aortic dissection. If the osteas are minimally disrupted, sorry, there are two messages. Okay, so if the, excuse me, if the osteas are minimally disrupted, you can repair them. And if the ostia are circumferentially disrupted during root replacement, you can either excise the coronary buttons and reunite them to the graft, or use a technique, reimplant them to the graft as the modified Bental procedure, or use a separate 8mm graft and anastomose this two ends of the graft to both coronaries, and anastomose that graft end to side to the aortic graft, called the caprol technique. I will show you right now. The last resort is when you cannot do any of these, you can do the aortocoronary bypass. This is what I mentioned. This is the implantation of the coronary buttons into the aortic graft, and this is the caprol technique. When you use a graft, attach them to both coronaries, and then you anastomose this graft to the aorta.
What's the size of this graft?
I think it's 8 or 10mm. I wrote 8. Okay, so for the descending aorta, in order, if the descending aorta is affected.
Sorry for interruption. Are you sure 8?
I think I read 8, yes.
8 it seem big. 8 نفس اللي نستخدمه في ال subclavian أو ال axillary cannulation. Dr. Farid?
Hussein, I think 8, and you will suture it into the button, to the extra tissue around it. Am I right?
So it has been reported as 8. We have used most of the time 6 with Crawford and his team. Most of the time we have used 6. Yes, you can sew it to a larger button, but then the flow will be limited by the coronary and you may have thrombus formation. I had one patient coming back with completely thrombosed right limb to the right coronary artery.
Okay, so for the descending aorta, for the management of the descending aorta and type A aortic dissection, there are advantages if you want to extend your repair to involve it. You would decrease the risk of malperfusion, and also you would decrease the risk of aortic aneurysmal degeneration and rupture, and you would decrease the rate of late reoperation due to other complications. It can be performed in 2 techniques. I am not sure if I understand these techniques right. These are 2 separate techniques. You have the elephant trunk repair or the frozen elephant trunk repair, which is the hybrid, right? Or I am not.
Yes, I think you're right.
Yes.
So in the hybrid, you will continue the procedure with the endovascular stent.
Okay. So for the elephant trunk repair, it's technically generally the same. You would repair the ascending and the arch, and you would use a skirted graft in order to insert it inside the descending aorta, and you will expand it inside with an open technique. While the frozen elephant trunk, you will first do the ascending and the arch, and insert the descending thoracic aortic graft through over a wire, and then deploy it. And also you will overlap it with your previous ascending and arch graft. And the management of the brachiocephalic vessels, you have the option of either debranching or using a graft with branches for each vessel. So for the post-operative management, you need invasive hemodynamic monitoring to ensure end organ perfusion. And post-op blood pressure control, you'll have to provide analgesia and sedation with a target blood pressure of 90 to 110. Also for the coagulopathy post-operatively, you will administer blood product, antifibrinolytic drug, normothermia also is an important part. You will do an ECG and chest X-ray looking for any complication post-surgery. Full physical exam for any new neurological deficits, and extubation is done for the patients when the criteria are met and the patient is hemodynamically stable and no longer bleeding. Long-term management of patient type A, type B, type A aortic dissection, you will need the long-term blood pressure control, maintaining less than 120 systolic. Follow-up imaging to monitor the aortic diameter. You can use spiral CT or MRI. MRI is preferable in patients who are young or pregnant ladies. One method I have read is that you can alternate. One time you can use the CT and the other is an MRI, but I don't know how you would standardize the measurements because these are two different modalities. The false lumen should be included also in the measurement. You don't only measure the true lumen during follow-up. Also, you can do an echo to assess the aortic valve. The timing of these imaging routines, you will do them first at baseline after repair, then at 6 months. This is the thing that mentioned in the book. In the book, it says at 6 months interval during the first year. So the first year you do it after 6 months, and then at the end of that year. If the aortic diameter is unchanged, you would do it yearly. If the aortic enlargement is more than 0.5 centimeters in 6 months, you will decrease the interval to 3 months. So you'll do it for every 3 months. I read and up to date that the interval for follow-up, you will do it baseline, 3 months, 6 months, and 1 year. And if there is no change, you will do it yearly. I think the guidelines for intervention are similar to the ones for aortic aneurysm. Same measurement, if I'm not mistaken. So the results.
Professor, can I ask, Dr. Farid, regarding CT and MRI, if we put a stent is compatible with MRI, but there will be a lot of artifact with MRI. So you recommend CT or MRI?
I don't know if it really makes a big difference, but we used to use CT. Recently, there's a concern about the radiation effect of CT and the long-term effect of cancer incidence in those patients. If they have many CTs and it's 10 years or later, they have higher incidence. I couldn't pinpoint how much increase in incidence and does it warrant the concern, especially if you're dealing with such a disease. So the answer is, I don't know. I don't think there's a big difference. I used to use, when I deal with those patients, the CT.
Thank you.
Okay, for the prognosis after the repair, replacement of the ascending aorta in type A obliterate the distal lumen in less than 10% of the patient. Rupture of the distal dissection usually was the cause of the late death in 30% of the DeBakey's patients and is still the leading cause of death. The operative mortality, originally in the DeBakey's cohort, it was 40%. Now it ranges between 10 and 30%. The causes of death are usually stroke, MI, heart failure, rupture, and malperfusion. In patients who are discharged alive after the repair, the survival rate after 1 year is 96%. Survival at 3 years is 91%, and the survival at 5 years is 71 to 89%, and at 10 years is 54 to 66%. So for type B, and I'll make it short because it took more than half an hour, I think. The type B accounts for 40% of all acute aortic dissection. Most of the patients survive the acute and subacute phase of the medical management. A type B aortic dissection is considered complicated if there is an imminent or actual rupture, and the signs of imminent or actual rupture are either mediastinal or periaortic hematoma. Aortic expansion, hemodynamic instability, persistent pain despite medical therapy, drug-resistant hypertension, or malperfusion syndrome. The most frequent cause of death for patients with type B is rupture and malperfusion. Medical management is the mainstay of treatment for patient type B. Usually, medical management is enough, and it showed good results. So in-hospital survival, showed in-hospital survival of 90% and survival at 1 year of 85%, and survival at 5 years was 71.5. The mortality rate for patients who were managed medically was 30%. There was a trial called the NSTED, and its long-term follow-up.
You mean surgically?
Sorry?
Slide.
The mortality rate of medical patients, yes, it was 30%.
This is for medical patients.
Medical patients.
Okay, thank you.
So medical management, it is the mainstay of treatment, and the choice that is mostly chosen. It was shown in a trial called the NSTED and the NSTED Excel trial. It's a trial where it was a randomized control trial of 140 patients with type B without complications. Compared endovascular plus medical or medical only. In the 2-year follow-up, which is the NSTED trial, there was no significant difference in survival between those patients. So 89% in the medical only and 96% of the endo and medical. Favorable aortic remodeling was seen in the endovascular group treatment. It was 91% of them had favorable remodeling, while 19.4% in the medical. In the NSTED Excel, which is a 5-year follow-up, there was also no difference in the all-cause mortality. 11.1% was in the endovascular and 19.3% in the medical. But the significant difference was in the aorta-specific mortality. 6.9% of the patients with the endovascular treatment and medical died because of an aortic catastrophe, or 19.3% in the medical treatment only died because of aortic causes. And there was also significance in the progression. 27 patients progressed in the group of endovascular, while 46.1% progressed. And these were the significant findings in these studies. So endovascular treatment showed mortality after 5 years in the aortic specific mortality and aortic dilatation. So the medical treatment for type A is similar to type B is similar to type A. You do the anti-impulse therapy, pain control. You would give the patient IV fluid if the patient is in shock or hypotensive. Once the patient is stable, you can change his medication to oral and discharge him with the follow-up. Imaging and clinical follow-up at 3 months, then you can do it every 6 months if the patient is stable. The indication of surgeries for surgical intervention or operative intervention is, as we said, complications. It is mentioned on this table. There are no questions.
Okay.
The operative technique for invasive management of type B aortic dissection, you have the option of either the endovascular management through endovascular grafts or the surgical management. And the surgical management, either you have the less invasive, the endovascular stent or fenestration, endovascular graft and stenting and fenestration. For the surgical management, you have 2 options. Either you would do replacement with an endograft, with an aortic graft, or you would do surgical fenestration. For the replacement, the surgical replacement, there are two techniques. One which is old, and I don't think anyone is using it right now, which is the clamp and saw without a bypass. And the left heart bypass, which is utilizing bypass technique, which is only bypassing the left side of the heart by having a cannula in the left, in the pulmonary vein and left upper pulmonary vein, and another cannula in the descending abdominal aorta or the femoral artery. This is just a fast summary of, this is the surgical fenestration, and this is the steps of descending thoracic aortic repair. Thank you, and sorry for taking a long time.
Very good lecture, Professor. Thank you very much.
Thank you. يعطيك العافية.
يعطيك العافية.
عجبتني الصراحه مسكرت مرتضى وين اكتفى.
ايش بيني بينك انا يا دكتور خالد؟
بس مبش الرجال تقول نص ساعه ربع ساعه مش بعد روح تقاطع يعني.
ما خلصت نص ساعه، باقي 7 minutes. اقدر اسالك كويستشن تاني. زين انا كنت بسال، طيب بالنسبه للاندوفاسكولار تريتمنت فور uncomplicated type B dissection، اذا كان if the patient is stable uncomplicated يعني stable patient، الاندوفاسكولار في الترايل هذه في instead XL, do you know if they did the endovascular treatment at the index admission ولا they did it electively يعني they treated the patient medically, discharged the patient
electively. يعني they did it before without this indication يعني without an indication. عرفت any patient they did for him stent even he did not meet an indication. وقال لك إنه remodeling حق الستنت أحسن. ف this is may open a new era where they will do stenting for all patients with type B dissection.
اي حتى المورتاليتي الاورتيك ريليتد مورتاليتي كانت less significantly less. طيب
I think Dr. Farid preferring to stent all patients regarding to the symptoms or complication.
ما شاء الله عليك. أعرف ولا شيء، لكن فعلا you have to realize that with this current technology there is a trend and they are challenging medical treatment, and yes, it has better complication, better mortality rate, so it probably will take over once they go over the learning curve.
Great. So Dr. Abdurrahman Roeli, are we